Welcome to this educational video brought to you by the Society of Mechanical Ventilation. Modes of mechanical ventilation. Airway Pressure Release Ventilation. APRV.
Hi, in this talk we'll be talking about APRV. We'll try to explain what is APRV, what the benefits and risks of using APRV, when to use it, how to set it, and future research, some ideas for future research. To be honest, not a single mode that I know has been more controversial than APRV, despite being very beneficial. And there's multiple reasons for this. Some include the problems with its name. There's so many names in different ventilators for the same mode. A lot of research using the so-called APRV, but with really different settings. In this slide, this is an article we published a long time ago, 2012, and talks about all those issues. There has been very few new things since then, and we'll try to talk about them during this talk. So what is APRV? And simply put, APRV is a pressure-controlled mode that is inverse ratio, as you can see in the figures here, very long inspiratory phase and very short expiratory phase. We'll talk about the lingo of APRV that allows unrestricted spontaneous breathing on the top of the mandatory. As you can see in this figure, this old figure we published in 2007, you can see these are the mandatory breath with some spontaneous breathing on the top. So not to confuse intermittent mandatory ventilation with SIMV, because in SIMV, whether it's pressure or volume, each time the patient breathes on the top of the ventilator, it will be a brand new breath, versus here in APRV, it will be only a breath on the top of the mandatory breath. So let's take a look at the figures, or let's talk first about, as we said, the lingo of APRV, and we'll apply it to the figures. So there's 5 terms used in APRV. Number 1, P high, which is a pressure high, which is basically the inspiratory pressure. P low, or the expiratory pressure, or PEEP in other modes. It's this short one. T high, or time high, which is basically the inspiratory time. I don't know if you can see in this figure or not, but you can see here, this is the P high, and this is the time high, T high. This is the P low, the pressure low, and that's the time low, or the expiratory time. Basically, releases are how many mandatory breaths in each minute. So if you set, for example, the T high at 5.6 seconds and the T low at 0.4 seconds, it means that there will be 10 releases per minute, 10 of those. And the patient can breathe again on the top as much as he wants, whatever his respiratory rate. So in this figure, again, that's the airway pressure. As you can see, it's a pressure controlled mode. Very long inspiratory time, definitely inverse ratio. Here it's like almost 5.6 is T high and 0.4. So almost the ratio is almost 15 to 1 or more. This is the inspiratory flow, that's the mandatory one in light blue. And there is a little blip here, I don't know if you can see it, and this is the spontaneous inspiratory flow and the expiratory flow of the spontaneous of the patient. This is the mandatory expiratory flow, and of course, as you can see, that does not return back to baseline, so there is auto PEEP, and that's how APRV usually set as to create auto PEEP intentionally. That's a tidal volume. As you can see during the release, there's an extra blip here, and that's the extra inspiratory effort or the inspiratory cycle of the patient on top.
Okay, we'll talk about the settings again in this live simulator. So this is the mode APRV. The settings are the pressure high, P high, in this example 25, P low, in this example 0. Most of the time we try to set it at 0, but the reality is because of the T low is very low, very short, the airway pressure really never goes down to 0. The time high, T high, in this example 4.6 seconds, and the T low 0.4 seconds. So that gives you a mandatory breath of 12. Of course, you said the flow trigger and the oxygen. Some other ventilators would have the option of pressure support, that you dial it on top of the spontaneous breath. Only happens in the spontaneous breathing. This patient here in this example is not having any spontaneous rate, but again, as you can see, that the pressure high at 25 goes up for 4.6 centimeter, then the airway drops very quickly down to supposedly 0, but again, most of the time it doesn't go to 0 because of the very short T low, then restarts again. And as you can see, the expiratory flow very deep because this patient is ARDS, very returns back very quickly, and because with very short time constant, and starts again. Now, most of the time we try to have patient on APRV having spontaneous, some spontaneous effort, because that's one of the advantages of APRV. So as you can see here, as you can see the difference, this is a spontaneous inspiratory and expiratory flow. You can see it was like in the sinusoidal shape, and of course different than the mandatory one, which is a decelerating waveform. You can see it here in the flow, and you see it here in the airway pressure. And of course the tidal volume will change during the spontaneous effort, depending on how strong is the effort is. So if we increased the patient effort, you will notice that the tidal volume during the spontaneous effort can go very much higher. Let's talk about the setting of APRV, how we're gonna start our initial settings at least. And there's multiple ways, and I would really encourage you to read that article because we talk about in details about the different ways, so the video doesn't become too long. But in this case, this example, this patient is on volume control uh, with the constant flow, the pink one, and I put some inspiratory pause here to get a plateau pressure. This is the esophageal pressure and transpulmonary pressure that we talked about in a previous talk. So one of the ways some people can do is obtain a plateau pressure and set it the P high accordingly. In this example 23. If it's higher than that, most of the time you can use a little bit P high, a little bit less than the plateau pressure. If the patient, for example, on pressure control mode, this person is on a driving pressure of 15 and PEEP of 10, so the plateau pressure is about 25. Good place to start. Some other ways of doing it is, again, if you have an esophageal balloon or you use it, to look at the transpulmonary pressure the inspiratory and inspiratory transpulmonary pressure. For this example, it's 18, and try to keep it between 15 and 20. One other way of setting it is to obtain a pressure volume curve, although that sometimes could be difficult if the patient has spontaneous effort. And as we talked, you want your patient on APRV to have some spontaneous breathing, so you might not get a very accurate pressure volume curve. For this example, we're doing it, the patient is passive, we then switch to APRV. Here you can see like there is this peak, so if you put him at around 30, more than 30 p high, now you're developing that peak, which means it's like too much pressure. So you try to get it at the high inflection point, which is around, in this case, around 30. You can see here, we can move the cursor a little bit to see where's that point at the arrow. Yeah, so it's like about 25. So you can set your P high below that. So we'll put our patient according to those settings. We'll switch to APRV, and we'll start with the P high around 25. In this example, I put the patient on 4.8 second T high and T low 0.2 seconds, and we'll talk about this. So our patient here, as you will see, his P high is 25. The transpulmonary pressure and inspiratory transpulmonary pressure here is about 18, and we have an esophageal pressure of about 7. So those are some of the ways for setting P high. Now let's move on to talk about P low. How are we gonna set P low? And I should have mentioned in the previous slides that there is really no comparative studies on how to put the settings, and mostly it's an expert opinion on how to do these things, or according to some physiologic concepts or theory, but there's really no studies to compare them. Now the P low, most of the experts, they set it at P low. I do the same too, and the reason is, as we'll talk in the next slide about the T low, we are intentionally trying to create O2 PEEP, and if you add P low, the difference between, which is the driving pressure between the P high and the P low, will be shortened, and it might affect the release volume. So setting it at P low and depending on creating O2 PEEP might actually makes more sense. Some people don't like that, and they add their own P low or PEEP. For this example, I know you can see it, but the tidal volume is about 380. So if we say put P low of 10, now you're gonna see the driving pressure will be the difference. 25 minus 10 will be 15, and the tidal volume already actually dropped down to 280. So it makes logical sense to put the P low at 0 and try to depend on the O2 PEEP. The question becomes is how much O2 PEEP we are creating, and we'll talk about this in the next slide. Now moving on to the T high, the time high or inspiratory time. And as we talked before, this is an inverse ratio. In severely hypoxic patients, you want the highest T high possible. And for many reasons, most importantly, is the longer the T high, the longer the alveoli are stable and re- decrease that opening and closing of the alveoli. So you're basically ventilating the lung most of the time on the opening pressure of the lung. So you want the T high to be high enough for all the alveoli to be recruitable, and it's called the open lung approach. If, of course, you can look later and see if your end-tidal CO2 or your PA CO2 is getting uh, too high, like too high. um, you can reduce the T high. For this example, it's 4.8 seconds and T low 0.3 seconds. So there's 12 mandatory respiratory breath. So you can try to decrease it a little bit if again your PA CO2 is high. Um, and you want also the patient to be having his own spontaneous breathing. As we said in this example, the patient is actually passive. I can't make him to breathe, but you want the patient to participate almost 20-30% of the minute ventilation, because that will help get rid of the CO2 and will also have some additional benefit, opening those collapsed dorsal lung units by reducing the pleural pressure. Now the T low, perhaps the most important setting in APRV is the T low. If you look at the literature, there's again multiple ways of setting it. A lot of the articles out there just tell you empirical number between 0.2, 0.3 up to like zero point 0.8 or zero point 0.9 seconds. And again, this is very non-physiologic, because if you have a patient with severely low compliance, whether it's from the lung or from the chest wall, and the time constant is very low, even zero point 0.4 seconds in this example might be too long, and I'll show you why. Some other experts wrote that you have to set the T low, so according to the peak expiratory flow, when it decays down to like 50, between 50 or 75%, you set that T low accordingly to create more auto peep according to the slope. And it makes a little bit sense, and I agree with it. The only problem is how much auto peep are we creating? And the answer is like really nobody knows. Some people say, okay, here you created auto peep, so really the airway pressure at the end of the release is really not zero as the ventilator is showing. But if you put that cursor here at the beginning of the breath, it's like intersecting, I think. Maybe it's okay, sorry, kind of hard to see, but maybe here, and it's intersecting at 14. So could that be the auto peep? Again, I'm not 100% sure about that. One study we published in a small amount of patients using again the esophageal balloon manometer and the transpulmonary pressure, and to try to exactly measure how much auto peep is there. So if we created the pressure volume curve that we did before, and we saw that we need at least the low inflection point is about 10 or 12, you try to create auto peep of around that point. Again, it might be hard because of the patient's spontaneous effort. You might not be able to get a pressure volume curve. So let's try do an expiratory pause maneuver that we usually try to get auto peep with. And look, so we did the pause here at the end of the release, and the airway pressure is about 8. The esophageal pressure, if you notice in this example, is 13. And if you can see, the transpulmonary pressure here is minus 5.2. So what that basically tells me is even 0.4 second, the airway pressure is not, or the auto peep created by 0.4 second is not enough. Because again, the time constant is very low. So let's reduce the Tlow at 0.2, and we'll retry the maneuver again. And again, the concept is to try to keep the end expiratory transpulmonary pressure above 0. So let's do it again. Expiratory pause. Okay. So here we have the airway pressure, the auto peep is 14.3. Our esophageal pressure is 14. So exactly we're getting a transpulmonary pressure, and expiratory transpulmonary pressure is 0.3. So in this case, Tlow might be good, 0.2. But if you do it empirically, again, you might not be knowing what's happening inside the alveoli. And if you can see in this example, the peak expiratory flow is like about 110, and the breath starting about here, the flow is 57, so it's about 50%, not 75%, but it's actually working good. Of course, the amount of auto peep will depend on the tidal volume. It will depend on the P high. So of course, if I raise the P high, that will affect how much the release volume, and might affect the auto peep that we are creating. And of course, the respiratory mechanics, changing the respiratory mechanics or the compliance will affect that. So let's do this maneuver one more time to see what the effect of the increasing the P high. Here we did the expiratory maneuver, pause maneuver. Now the airway pressure at the end of exhalation of the release is 15, the auto peep. Our esophageal pressure is still about 14, and our transpulmonary pressure is 0.9. So how do we wean a patient from APRV? And there's multiple ways of doing that. Remember, APRV initially was described as 2 levels of CPAP, or continuous positive airway pressure, the high one and the low one, with intermittent drop of the pressure or the release. As the patient improves and the compliance and the resistance improve, you will notice that the tidal volume of the release should start to improve, of course, as when the clinical condition also improve. So there is the way called the stretch method. Basically what it is you start dropping the pressure high, and at the same time prolong the T high to try to maintain a mean airway pressure. At the same time reduce the number of releases. So if we see in this case our patient is in T high 4.6, T low of 0.4, so that gives like mandatory breath of 12, his in pressure high of 30, and P low of 0. So this is an ARDS patient. So if we try to make him start to improve and make him as a normal person, normal lung mechanics, I'm sorry, you will start noticing that the tidal volume, like here, will start to increase, which, if it's not because of the spontaneous effort, In this case, the patient is improving, the mechanics is improving, so now the tidal volume is getting very high. So what we'll do is we'll try to go down on the pressure, of course, stepwise. I'm just gonna do that. We're gonna reduce the release rate. So instead of making it, for example, 12, we'll increase the T high, for example, 5.6, and we decrease the pressure high. And now, then we'll watch the patient. Again, the patient's still doing good. We'll further start coming down on the pressure high again gradually. Let's make, almost try to convert him into one level of CPAP. Usually I try to get down that to like 1 or 2 mandatory breaths or continuous CPAP. Some ventilators would not allow you to have 0 releases, but or you can just switch the patient, of course, to CPAP only. You put them in PEEP or you put them on pressure support. But I just wanted to show how do we adhere the stretch method. So again, on pressure of 17, we'll keep coming down, and usually once you're around 7 or 10 of pressure high, and for example, 4 or 5 releases, and the patient is doing well, hemodynamics okay, oxygenation okay, the release volume is okay, and of course you have to follow your extubation guidelines. But once he's on those settings and his still tidal volume is good, then you can, patient is ready to be extubated. You don't have to switch into another mode of weaning. He already did the weaning already.
The advantages of APRV are really numerous, and if you look at all the literature, um, improved oxygenation has been proved over and over, whether in animal studies or human studies. And the reasons are, there's multiple reasons and theories. One of it is the high mean airway pressure that you get with APRV. Really hard to get that with conventional ventilatory modes. As you can see in this slide, that's how you calculate the mean airway pressure, which is the T high times the P high, plus the P low times the T low over the T high and the T low. Recruitment, as we said before, the very long T high on the high P high, the pressure high, that opens the alveoli, and alveoli has different time constants, so some open fast, some takes time, so by the time the end of the T high, lots of alveoli are open. By reducing the opening and collapse of the alveoli, you might reduce ventilator-induced lung injury or ventilator-associated lung injury. One theory, and we did that small studies that showed that just the application of APRV reduced the extravascular lung water in ARDS patients, and that correlated also with higher mean airway pressure. So multiple reasons APRV can improve oxygenation. Number 2, improved hemodynamics, and again, multiple studies in animals and humans showed that the blood pressure, the cardiac output, the kidney perfusion has improved with APRV. And sometimes we kind of get to forget the perfusion part during respiratory failure. We always think about the lung, and we kind of forget the ventilation, we forget about the perfusion. But you have to have a good perfusion also to match the ventilation. Now, as we said before, you need the patient to have some spontaneous effort, spontaneous breathing, and that has shown to also improve oxygenation, especially also the dorsal area of the lungs that are usually heavily collapsed, because that might reduce the pleural pressure and open those alveoli. Despite being an inverse ratio, and we all know, like in regular conventional ventilation, if you put the patient in inverse ratio ventilation, it's very uncomfortable. Sometimes we have to like heavy sedate those patients. But here, because of the patient can breathe at any time during the respiratory cycle, so the patient is comfortable, and actually most of the studies shows that you use less sedation. Now mortality, and that's the important part. I used to be asked, why do you use this mode that hasn't shown any mortality in ARDS? And I don't really believe that the mode itself alters the mortality. And if there is one mode that can improve mortality, then there's no reason not to use that mode. I think any mode, if used correctly or less dangerously, can improve mortality. But anyway, in the last couple of years now, we have some more evidence, some studies from China and some meta-analysis that should, compared to conventional ventilation, APRV might improve mortality in ARDS. So when do we use APRV and when are we not supposed to use APRV? And I'll make that simple. I think you can use APRV in any sort of respiratory failure, whether it's pneumonia, ARDS, and actually the expansions. We used to use it as more of a rescue therapy after failed conventional ventilation, but the literature now showing it might improve like recruitment of organs for donation. It might reduce ventilator-induced lung injury and prevent ARDS. So you can use it as any other mode in any other situation. When not to use it, when contraindication, and I don't think there is really any strict contraindication. People would say before, don't use it in COPD or obstructive lung disease. I don't think that's the case if you use it carefully with careful settings. I don't think there's any contraindications for it. So some questions I think we need to answer, and maybe would be good for future research. I think we still need to understand more how APRV works. We need to see what's happening inside, whether with an esophageal balloon or maybe with electrical impedance tomography, see the difference between ventilation and perfusion. So again, we need more understanding. Maybe we need better research in comparing different settings in APRV. We definitely need more education in APRV and more understanding. With that, I'll tell you thank you for listening. I hope that was beneficial. See you in the next talks.